Hello dear learners, greeting from me. Hope so you all are safe and doing well. Today I am going to deliver one more video on the topic of non-steroidal anti-inflammatory agents, NSAIDs, analgesic and antipyretic. Hope so you will like it. So after watching this video, don't forget that like, share and subscribe my channel. In today's lecture, I am going to discuss about the introduction of NSAIDs and antipyretic, general mode of action of NSAIDs, classification of NSAIDs, SAR, mode of action and metabolism of salicylate and acetaminophen, disease modifying antirheumatic drugs and drugs used in treatment of gout. Introduction of NSAIDs. Non-steroidal anti-inflammatory drugs are drugs with analgesic, antipyretic, lowering and elevated body temperature and relieving pain without impairing consciousness and anti-inflammatory effect. The term NSAIDs is used to distinguish these drugs from steroids which have a similar eicosanoid depressing anti-inflammatory effect. These drugs not produce physical dependence or addiction, so it is referred as non-narcotic analgesics. Inflammatory effect of eicosanoids. How eicosanoids produce inflammation in our body are elaborated in this figure. Generally, bradykinin and histamine increase the vascular permeability, vasodilation and pain, and this is all are the mediator of inflammatory effect. Mast cell degranulation and histamine release produce the inflammatory effect. Neutrophil activation, chemotaxis and phagocytosis also produce the inflammation. Cell lysis produce inflammatory effect of component. Thrombin produce fibrin deposition and fibrin deposition cause inflammatory effect of component. So this is all are the mediators of inflammation. Introduction of COX enzyme. Cyclooxygenase, also known as prostaglandin H synthase enzymes, catalyze the conversion of arachidonic acid to prostaglandin H2, the common biosynthetic precursor to prostaglandin and thromboxane. The pharmacological effect of NSAIDs arise from their inhibition of COX enzyme. To date, 3 isoforms of COX have been identified: COX-1, COX-2 and COX-3. COX-1 is constitutively expressed in most tissue and is required for the production of prostaglandin. COX-2, the expression of which is inducible by cytokinins and growth factors. It has been long known that acetaminophen possesses analgesic and antipyretic activity but little if any anti-inflammatory activity. So the identification of COX-3 can be of importance because COX-3 is selectively inhibited by analgesic antipyretic drugs and is potentially inhibited by some NSAIDs. Inhibition of COX-3 can represent a primary central mechanism by which acetaminophen decrease pain and fever. Mode of action of non-steroidal anti-inflammatory drugs. Essential fatty acid produce membrane phospholipids. These membrane phospholipids produce arachidonic acid with the help of phospholipase A2 enzyme. All the steroidal anti-inflammatory drugs like betamethasone, they all are produce its effect by the inhibition of phospholipase A2 enzyme. Okay. Now arachidonic acid are converted into leukotrienes and the prostaglandin H2. Arachidonic acid convert into prostaglandin H2 by the help of COX enzyme, and this COX enzyme inhibited by the non-steroidal anti-inflammatory drugs. And prostaglandins are short-lived lipid-like molecules that play a vital role in modulating many important physiological and pathophysiological functions, including pain, inflammation, gastric acid secretion, wound healing, and renal function. They are biosynthesized via a tissue-specific cyclooxygenase pathway, either on an as-needed basis or via the induced and overexpressed COX-2 isoenzyme because of an injury, inflammation or infection. Some of the silent features of the cyclooxygenase pathway involved in the biosynthesis of these prostaglandins from arachidonic acid, a polyunsaturated fatty acid released from membrane phospholipids by the action of phospholipase A2. As stated earlier, all classes of nonsteroidal anti-inflammatory drugs strongly inhibit prostaglandin synthesis in various tissues, especially at the site of the tissue damage or inflammation. This inhibition occurs at the stage of oxidative cyclization of arachidonic acid catalyzed by the rate limiting enzyme COX or PGH synthase to the PGG2 and its subsequent reduction to key intermediate prostaglandin S2 required for all prostaglandin biosynthesis. Blockade of prostaglandin S2 production thus prevent its further conversion by tissue specific terminal prostaglandin synthase or isomerase into different biological active prostaglandins including PGE2, PGD2, PGF2, PGI2 and thromboxane A2. Among the prostaglandins synthesized by the action of either COX-1 or COX-II isoenzyme, prostaglandin I2 and prostaglandin E2 made at the site of injury via COX-II isoenzyme in the inflammatory cells such as monocytes and macrophages and also in the brain are known to play a dominant role in mediating inflammation and inducing hyperanalgesia. Now generally main side effect of NSAIDs is gastric ulcer or GI disturbance. So I would like to discuss about the reason for the NSAID side effects. Prostaglandin synthesis in the gastrointestinal tract via COX-1 isoenzyme and in the renal tubules via COX-1 and COX-II isoenzyme is essential to provide cytoprotective action of restoring the integrity of the stomach lining and maintaining renal function. So inhibition of prostaglandin E2 synthesis by the conventional non-steroidal anti-inflammatory drugs in the parietal cells remove its ability to modulate histamine mediated release of gastric acid from the parietal cells, whereas blockade of PGI2 and PGE2 synthesis in the epithelial cells in the stomach lining also prevent their action on the biosynthesis and release of bicarbonate and mucus gel desperately needed to repair damage resulting from erosion caused by gastric acid and other aggressive factors. Now classification of NSAIDs. NSAIDs are broadly classified into three categories. Number 1, non-selective COX inhibitors and examples like salicylate, aryl and heteroaryl acetic acid, aryl and heteroaryl propionic acid, and aryl antranilic acid and miscellaneous agents. Selective COX-2 inhibitors like celecoxib, etarocoxib, rofecoxib, valdecoxib, etc. And antipyretic analgesic example is acetaminophen and phenacetin. Non-selective COX inhibitors from this class, first agents is salicylates. History of salicylates. The use of salicylate dates back to the 19th century. Salicylic acid itself was first obtained in 1838 from salicin, a glycoside present in most willow and poplar bark. Interestingly, Hippocrates prescribed chewing willow bark for pain relief in the 5th century. In 1860, Kolbe synthesized salicylic acid from sodium phenoxide and carbon dioxide, a method that inexpensively produced large quantities. Derivative of salicylic acid began to receive medical attention shortly thereafter. Sodium salicylate was employed as an antipyretic antirheumatic agent in 1875 and the phenyl ester was used in 1886. Acetyl salicylic acid was prepared in 1853 but was not used medicinally until 1899. Since then, numerous derivatives of salicylic acid have been synthesized and evaluated pharmacologically, yet only a relatively few derivatives have achieved therapeutic utility. Now, use of salicylate. In addition to possessing antipyretic, analgesic and anti-inflammatory properties, salicylate possesses other actions that have been proven to be therapeutically beneficial. Because salicylate promotes the excretion of uric acid, they are useful in the treatment of gouty arthritis. More recent attention has been given to the ability of salicylate to inhibit platelet aggregation, which can contribute to heart attack and stroke. Aspirin appears to inhibit prostaglandin COX in platelet membranes, so blocking formation of the potent platelet aggregating factors thromboxane A2 in a manner that is irreversible and useful in myocardial infarction. Mode of action of salicylate. A number of possible mechanisms of action have been proposed for salicylate over the years. Among those that have been suggested are inhibition of the biosynthesis of histamine, antagonism of the action of various kinins, inhibition of mucopolysaccharide biosynthesis, inhibition of lysosomal enzyme release, and inhibition of leukocyte accumulation. Aspirin is the only NSAIDs that covalently modified COX by acetylating serine 530 of COX-I and serine 516 of COX-II. These 530 and 516 are the position of amino acid in the enzyme. Aspirin, however, is 10 to 100 times more potent against COX-I than against COX-II. Aspirin's action on COX-I prevent both endoperoxide and 15-peroxidation of arachidonic acid, but its action on COX-II does not prevent formation of 15-peroxidation of arachidonic acid. Structure-activity relationship of salicylate. This is the structure of salicylic acid, and numbering start from the carboxylic functional group 1, 2, 3, 4, 5 and 6. Despite the vast effort that has been expended in the search to find a better aspirin, that is one possessing fewer GI side effects but a greater potency and longer duration of action, it is inexpensive and an antipyretic, analgesic and anti-inflammatory agent that is overall superior to aspirin, none has yet to be discovered. The active moiety appears to be the salicylate anion. The side effect of aspirin, particularly this GI effect, appears to be associated with the carboxylic acid function. Reducing the acidity of this group, example converting to an amide containing molecule such as salicylamide, maintain the analgesic action of salicylic acid derivatives but eliminate the anti-inflammatory properties. Substitution on either the carboxyl or phenolic hydroxyl group can affect potency and toxicity. Benzoic acid itself has only weak anti-inflammatory activity, placing the phenolic hydroxyl group meta or para to the carboxyl group abolize the activity. Substitution of halogen atom on the aromatic ring enhance potency and toxicity. Substitution of aromatic rings at the fifth position of salicylic acid increase anti-inflammatory activity. Example is diflunisal. Drugs belongs to salicylate class is aspirin, salicylamide, sodium salicylate, sodium thiosalicylate, just difference is here, then magnesium salicylate, choline salicylate, salsalate and diflunisal. Metabolism of salicylate. The major metabolic routes of ester and salts of salicylic acid are illustrated in figure. The initial route of metabolism of these derivatives is their conversion to salicylic acid, which can be excreted in the urine as the free acid or undergoes conjugation with either glycine to produce the major metabolite salicyluric acid or with glucuronic acid to form the glucuronide, ether and ester. So aspirin, salicylate ester and salicylate salt are converted or metabolized into salicylic acid. This salicylic acid are conjugated with glycine with the help of glycine N-acyl transferase enzyme and produce salicyluric acid. Also it conjugate with the glucuronic acid and to form glucuronide, ether and the ester moiety. This is the ester moiety and this is the ether moiety of glucuronide. Some of the salicylic acid undergoes microbial aromatic hydroxylation and produce xanthasic acid. The major hydroxylation metabolite xanthasic acid was once thought to be responsible for the anti-inflammatory action of the salicylates, but its presence in trace quantity would rule out a major role for xanthasic acid or the other hydroxylation metabolites in the pharmacological action of salicylates. The most commonly observed side effect associated with the use of salicylate relate to disturbance of the GI tract, nausea, vomiting, epigastric discomfort, intensification of symptoms of peptic ulcer disease, gastric ulceration, erosive gastritis, and GI hemorrhage occur in individual on high dose of aspirin. Second class from the non-selective COX inhibitors is aryl and heteroaryl acetic acid. This group of non-steroidal anti-inflammatory drugs has received the most intensive attention for new clinical candidates. As a group, they show high analgesic potency in addition to their potent anti-inflammatory activity needed for treating inflammatory disease. Among the members of this class, ketorolac, indomethacin and tolmetin have the highest risk of GI complication because of their high affinity for the COX-1 enzymes, whereas ketorolac has the lowest risk because of its COX-2 selective inhibitory action. Both sulindac and nabimeton are prodrugs that require activation and therefore have lower risk of causing GI irritation than indomethacin. Drugs belongs to this class are diclofenac, aceclofenac, fanclofenac, ketorolac, indomethacin, sulindac and nabimeton. This is the structure of various drugs belongs to aryl and heteroaryl acetic acid, diclofenac, aceclofenac, fanclofenac, indomethacin, sulindac, ketorolac, then tolmetin, zomipirate. Third class from the non-selective COX inhibitors is aryl and heteroaryl propionic acid. These are perhaps the most widely used drugs worldwide because three members of this class, ibuprofen, naproxen and ketoprofen, are now available without a prescription. All of the members of this class except oxaprozin contain a chiral carbon in the alpha position of the acetic acid side chain. Even though most are marketed as regimens, only the S enantiomer was found to have any inhibitory activity against the COX enzymes. So, the S enantiomer is believed to be solely responsible for the observed therapeutic action as well as the drug-induced GI side effects and nephrotoxicity. Furthermore, in most cases, the inactive R enantiomer is epimerized in vivo via the 2-aryl propionyl coenzyme A epimerase enzyme to its active S enantiomer. Drugs belongs to aryl and heteroaryl propionic acid are ibuprofen, in which there is a propionic acid attached to the aromatic ring, ketotiprofen, same way propionic acid attached to the aromatic group, phenoprofen, suprofen, flurbiprofen, naproxen, indoprofen and oxaprozin. Now fourth class from the non-selective COX inhibitors is N-aryl anthranylic acid. It is commonly called as phenamic acids. The anthranylic acid class of NSAIDs is the result of the application of classical medicinal chemistry bioisosteric drug design concept because these derivatives are nitrogen isoester of salicylic acid. Additionally, they could be considered structural analog of the aryl acetic acid derivative diclofenac. The second aromatic ring in this class is connected to the main aromatic carboxylic acid containing ring through a secondary amine linkage. As a result of these structural features, this class of NSAIDs appear to have a lower risk of causing GI irritation. The fact that this class of compound possesses little advantage over the salicylate with respect to their anti-inflammatory and analgesic properties has diminished interest in their large-scale development relative to the aryl alkanoic acids. Drugs belongs to phenamate class, mefenamic acid, meclofenamate and flufenamic acid. So, the main ring which contain carboxylic group are attached with the another aromatic group with the help of secondary basic nitrogen. Now, fifth class from the non-selective COX inhibitors is oxycum. Oxycums, the enolic acid class of NSAIDs, has been termed oxycums by the US Adopted Name Council to describe the series of 4-hydroxy-1,2-benzothiazine carboxamides that possess anti-inflammatory and analgesic properties. This structurally distinct substance resulted from extensive study by the Pfizer group in an effort to produce non-carboxylic acid, potent and well-tolerated anti-inflammatory drugs. The first member of this class, piroxicam, was introduced in the United States in 1982. Piroxicam is 200 times more potent than aspirin and at least 10 times as potent as any other standard agent in the ultraviolet erythema assay. Piroxicam inhibits the migration of polymorphonuclear cells into inflammatory sites and inhibit the release of lysosomal enzymes from these cells. It also inhibits collagen-induced platelet aggregation. It is an effective inhibitor of arachidonic acid cyclooxygenase, being almost equipotent with indomethacin and more potent than ibuprofen, tolmetin, naproxen, phenoprofen, phenylbutazone and aspirin in the inhibition of prostaglandin biosynthesis by methyl collaanthrin transformed mouse fibroblast MC5 assay. Now let's discuss about the second class of non-steroidal anti-inflammatory drugs is selective COX-2 inhibitors. COX-1 is beneficial in maintaining normal process in the GI tract by producing cytoprotective prostaglandins, stimulating bicarbonate secretion and mucus, and producing an overall reduction in acid secretion. The traditional NSAIDs inhibit COX-1 and COX-2 and also inhibit thromboxane synthase to varying degree of selectivity. Decreased gastric mucosal protection and stress-induced decreased renal perfusion result from non-selective inhibition of COX, whereas inhibition of thromboxane synthesis result in increased prostaglandin synthesis and a reduction in platelet aggregation and so an increased bleeding tendency. Those NSAIDs with a greater selectivity for COX-1 as a rule cause greater GI bleeding and renal toxicity than those with greater selectivity for COX-2. So the goal of developing an ideal NSAIDs, that is one that selectively inhibit COX-2, so reducing the inflammatory response but does not interfere with the GI protective function of COX-1. These efforts leads to the introduction of several selective COX-2 inhibitors in the US market like celecoxib, rofecoxib, lumiracoxib and valdecoxib. But safety risk and cardiovascular side effects leads to the removal of all coxib except celecoxib and the development of other selective COX-2 inhibitors such as paracoxib and etoricoxib has been halted. They are prescribed only for treating ankylosing spondylitis, juvenile rheumatoid arthritis, menstrual cramps, acute pain and osteoarthritis. Drugs belongs to this class is celecoxib, nimesulide, lumiracoxib, rofecoxib, valdecoxib, paracoxib and etoricoxib. The analgesic antipyretic, acetaminophen and related analogues. Introduction of antipyretic analgesic. From a historical perspective, acetaminophen, which is commonly known as paracetamol, and the related analgesic antipyretic drug such as acetanilide, antipyrine and dipyrone were introduced into the market about the same time as aspirin and the other salicylate. Example, acetanilide introduced in 1886, phenacetin introduced in 1887 and paracetamol introduced in 1893. This is structure of acetanilide, phenacetin and acetaminophen. Mode of action. Drugs included in this class possess analgesic and antipyretic action but lack of anti-inflammatory effect. Antipyretic exert their action within the central nervous system, primarily at the hypothalamic thermoregulatory center, but more recent evidence suggests that peripheral action can also contribute. Endogenous leukocytic pyrogens can be released from cells that have been activated by various stimuli, and antipyretic can act by inhibiting the activation of these cells by an exogenous pyrogen or by inhibiting the release of endogenous leukocytic pyrogens from the cells once they have been activated by the exogenous pyrogen. Substantial evidence exists suggesting a central antipyretic mechanism and antagonism that can result from either a direct competition of a pyrogen and the antipyretic agent at CNS receptor or an inhibition of prostaglandins in the CNS. Despite the extensive use of paracetamol, the mechanism of action has not been fully elucidated. Paracetamol can inhibit pain impulses by exerting a depressant effect on peripheral receptors, and antagonistic effect on the action of bradykinin can have a role. The antipyretic effect might not result from inhibition of release of endogenous pyrogen from leukocytes, but rather from inhibiting the action of release endogenous pyrogen or hypothalamic thermoregulatory centers. The fact that paracetamol is an effective antipyretic analgesic but an ineffective anti-inflammatory agent can result from its greater inhibition of prostaglandin biosynthesis via inhibition of the COX-III isoform in the CNS compared with that in the periphery. SAR of antipyretic. The SAR of para-aminophenol derivatives have been widely studied. Based on the comparative toxicity of acetanilide and acetaminophen, aminophenols are less toxic than the corresponding aniline derivatives. Although para-aminophenol itself is too toxic for therapeutic purpose. Etherification of the phenolic function with methyl or propyl group produce derivative with greater side effect than with ethyl groups. Substitute on the nitrogen atom that reduce basicity, reduce activity unless that substituent is metabolically labile. Example is acetyl. Amides derivative from aromatic acid, example is N-phenylbenzamide, are less active or inactive. Metabolism of antipyretic. Acetanilide and phenacetin are metabolized to acetaminophen. Additionally, both undergoes hydrolysis to produce aniline derivative that produce directly or through their conversion to hydroxylamine derivatives. Significant methemoglobinemia and hemolytic anemia which resulted in their removal from the US market. It has been known for more than 30 years that cytochrome P450 mediated metabolism is responsible for the hepatotoxicity of paracetamol. However, paracetamol undergoes rapid first-pass metabolism. In the GI tract primarily by conjugation reaction, with the O-sulfate being the primary metabolite in children and the O-glucuronide being the primary metabolite in adults. A minor but significant product of both acetaminophen and phenacetin is the N-hydroxylamide produced by cytochrome P2E1 and cytochrome P3A4. Cytochrome P2E1 is the rate limiting enzyme that initiates the cascade of events leading to acetaminophen hepatotoxicity. In the absence of this cytochrome P450 enzyme, toxicity will only be apparent at high concentration. The N-hydroxyamide is then converted to a reactive toxic metabolite and acid-imidoquinone N-acetyl parabenzoquinonamine that has been suggested to produce the nephrotoxicity and hepatotoxicity associated with paracetamol and phenacetin. Normally, this iminoquinone is detoxified by conjugation with hepatic glutathione. In case of ingestion of large dose or overdose of acetaminophen, however, hepatic stores of glutathione can be depleted by more than 70%, allowing the reactive quinone to interact with soft nucleophilic functional group, primarily sulfahydryl groups, on hepatic proteins and resulting in the formation of covalent adduct that produce hepatic necrosis. Metabolism of antipyretic. Generally, acetanilide and phenacetin majorly convert into acetaminophen. This acetaminophen majorly conjugate with glucuronide in adult and sulfate in child. But in minor way, the phenacetin produce aniline derivatives and also acetanilide produce aniline, and these both aniline derivatives are produce methemoglobinemia and hemolytic anemia. In overdose of acetaminophen, they are go through the another pathway and produce N-acetyl-imidoquinone derivatives. N-acetyl-imidoquinone itself is hepatotoxic metabolite detoxified by the help of glutathione conjugation. Also, it goes through the N-acetylcysteine conjugation. If there is a large dose of acetaminophen, then it is bind with the hepatic proteins and produce hepatic necrosis and renal failure. Disease modifying anti-rheumatic drugs, it is commonly called as DMARD. The synthetic disease modifying anti-rheumatic drugs include gold salts, hydroxychloroquine and sulfasalazine. Less common synthetic disease modifying anti-rheumatic drugs are penicillamine and minocycline. Synthetic immunosuppression used for the treatment of inflammatory disease include the antimetabolites like methotrexate, leflunomide and azathioprine. Now first, gold compound. Mechanism of action. The biochemical and pharmacological properties shared by gold compounds are quite diverse. The mechanism by which they produce their anti-rheumatic action has not been totally determined. The involvement of immunologic process in the pathogenesis of arthritis suggested that a direct suppression of the immunological response by gold compound was involved. Gold compounds. More recent study suggests that orenophine suppress the TLR4 mediated activation of the transcription factor and preventing the expression of cytokinins and COX-II. Orenophine has also been shown to decrease tumor necrosis factor A induced NF-κB activation, suggesting that effective inhibitors of NF-κB can be useful immunosuppressive and anti-inflammatory agents. This is the gold compound which are used as anti-rheumatic agents: orothioglucose, gold sodium thiomalate and orenophine. Next class in this group is aminoquinoline. The 4-aminoquinoline class of antimalarial drugs has been known to possess pharmacological action that are beneficial in the treatment of rheumatoid arthritis. Two of these drugs, chloroquine and hydroxychloroquine, have been used as anti-rheumatic since the early 1950s. The mechanism of action of these drugs as an anti-rheumatic remains unresolved. This is the structure of chloroquine and hydroxychloroquine. Immunosuppression. The discovery of drugs that modify the immune response, whether as immunoregulatory, immunostimulatory or immunosuppressive agent, has been the focus of much recent research activity. Several substances that suppress the immune system have been explored as anti-rheumatic drugs because the etiology of rheumatoid arthritis can involve a destructive immune response. Three molecules belongs to this category are leflunomide, this is structure of leflunomide, methotrexate and sulfasalazine. Now we will discuss about the drugs used to treat gout. Gout, an ancient and common form inflammatory arthritis, is characterized by elevated level of uric acid as urate ion in the plasma and urine and can take two forms, acute and chronic gout. Acute gouty arthritis result from the accumulation of needle-like crystal of monosodium urate monohydrate within the joints, synovial fluid and periarticular tissue and usually appears without warning. Chronic gout symptoms develop as permanent erosive joint deformity appears. The increase in extracellular urate can result from increased uric acid biosynthesis, decreased urinary excretion of uric acid, or perhaps a combination of both. Treatment of acute gout. The management of gout has been approached with the following therapeutic strategy. 1. Control of acute attacks with drugs that reduce inflammation caused by the deposition of urate crystals. And number 2, control of chronic gout by increasing the rate of uric acid excretion. Commonly it is called as uricosuric drugs. And inhibiting the biosynthesis of uric acid by inhibiting the enzyme xanthine oxidase. Treatment of acute gout includes NSAIDs such as indomethacin, colchicine and glucocorticoids. Okay, so this is the structure of indomethacin and colchicine which are used in acute gout. Now, treatment of chronic gout. Drugs that increase uric acid secretion. Probenecid promote the excretion of uric acid by inhibiting the urate anion exchange transporter, decreasing the reabsorption of uric acid in the proximal tubules. The overall effect is to decrease plasma uric acid concentration, thereby decreasing the rate and extent of urate crystal deposition in joints and synovial fluids. Sulfenpyrazone produces its uricosuric effect similar to that of probenecid. This is structure of sulfenpyrazone and probenecid. Another class in the treatment of chronic gout is that drugs that decrease uric acid formation. It was subsequently found that allopurinol serve as a substrate for xanthine oxidase. It have a 15 to 20 times affinity of xanthine and reversibly inhibit the enzymes. Normally, uric acid is a major metabolite and product in humans when allopurinol is administered. However, xanthine and hypoxanthine are elevated in the urine and uric acid levels decrease. When the synthesis of uric acid is inhibited, plasma urate levels decrease, supersaturated solution of urate are no longer present and urate crystal deposits dissolve, eliminating the primary cause of gout. Febuxostat, the first new drugs to be approved for the treatment of gout in over 40 years, is the first non-purine selective xanthine oxidase inhibitor marketed in the unlike allopurinol. Febuxostat non-competitively block the channel leading to the active site of both the oxidized and reduced form of xanthine oxidase, thereby inhibiting the synthesis of uric acid. This is the structure of allopurinol and febuxostat. Thank you.